So we continue with part 3 of our professional licensure exam. This is the supplementary part. Okay, so chemical pathology. So it's the same instruction. Choose the most appropriate answer only. Question 51. It says that when flow of blood is obstructed in the large vein by tourniquet, the increased filtration pressure will cause the following effect in the parameters indicated. A. Reduce aspartate transaminase. Then B. Reduce total bilirubin. C. Decrease potassium. D. Reduce total protein. And then E. Increase total iron. Okay. When you occlude the veins for the purpose of phlebotomy, there will be hemoconcentration. So when there is hemoconcentration, usually it results in increase in the electrolytes and then some proteins. If you analyze the options here, most of them from option A to option D, most of them is saying decrease. So A is saying reduce aspartate transaminase. So that will be incorrect. That will not happen when there is hemoconcentration. You may rather AST is more related to liver conditions rather than it increasing in when there is hemoconcentration due to a tourniquet. Then if you look at bilirubin 2, bilirubin 2 is not directly influenced by the use of tourniquet. And then if you look at potassium can increase when there is hemoconcentration. But in this case, the option is saying decrease potassium, so that's also not a viable answer. Then if you look at total protein, so the increased filtration pressure from the tourniquet typically can increase the protein's concentration. But this one, so the option is saying that reduce total protein. Then if you look at option E, it says increase total iron. And if you analyze this option too, there's no significant data or research showing that tourniquet application or hemoconcentration increases total iron. So if you analyze all these options, you realize that there's no viable option or there's no viable answer for this question. So this question, we have to leave it like that, unfortunately, and then continue, because all the options are not really selectable. Okay, so we continue with question 52. It says that hyponatremia A is usually due to excessive sodium losses. Then B is not commonly seen after surgery or trauma. Then C, in the syndrome of inappropriate secretion of ADH, is associated with low urine osmolality. Then D, we have maybe due to hyperemesis. Then E may be a feature of hyperthyroidism. Okay, the correct answer is maybe due to hyperemesis. So usually hyponatremia results when there is increased retention of water in the body, which will dilute the sodium and then reduce the concentration. So if you look at option A, for example, you do not commonly lose sodium by I don't know how to say it, like just like that. No, usually you rarely experience low sodium levels when there is high water retention. Then if you look at option B, it's not commonly seen after surgery. That is false, because in surgery you are going to take a lot of intravenous fluids, which can actually dilute the sodium concentration. Then if you look at option C, in the syndrome of inappropriate secretion of ADH, associated with low urine osmolality. So in the syndrome of inappropriate secretion of ADH, there is high level of water retention, which actually can cause hyponatremia. But if you continue, the option is saying that with low urine osmolality, that part of the answer is not correct, because one characteristic of inappropriate syndrome of inappropriate secretion of ADH is that there is high urine osmolality, and so that makes that answer not viable. Okay, then if you look at option D, maybe due to hyperemesis, this is correct, so that is the answer we are choosing, because hyperemesis can lead to hyponatremia due to the loss of sodium through the vomiting and potential volume contraction, leading to dilutional hyponatremia. So that is acceptable. And if you look at the option E, maybe a feature of hyperthyroidism. Hyponatremia sometimes can be a feature of hyperthyroidism due to mechanisms such as increased HGH secretion or altered renal handling of sodium, but there's not enough evidence backing this particular experience, and so we'll stick with option D, which is maybe due to hyperemesis. Okay, question 53. Estimated GFR, that's eGFR, A, is valid for all age groups, then B is a useful assessment of the progression of acute renal failure, then C can be useful to assess renal function in pregnancy, then D is the basis for the classification of chronic kidney disease, then E we have is the normal range rules out chronic kidney disease. Okay, so let's analyze our options, but first of all, the answer for 53 is D, is the basis for the classification of chronic kidney disease. Okay, so if you look at option A, for example, which is saying that it is valid in all age groups, that answer will not be acceptable, because eGFR is less accurate for younger children, and then in the elderly there will be variation of the results due to difference in muscle mass. So that answer will not be correct. If you look at option D, it's a useful assessment of the progression of acute renal failure. So eGFR may not be particularly useful in this case. It's only in the chronic situation that it's helpful. Then if you look at option B, it can be used to assess renal function in pregnancy. In pregnancy, it may be a little bit misleading because of the physiological changes that occurs in pregnancy. So that answer too, we will not accept that. Then D, it says the basis for the classification of chronic kidney disease. That is very correct, because the eGFR is a key component in the classification of chronic kidney disease. So it's used to stage the disease. So that's a correct answer. Then is E, saying that in the normal ranges it rules out chronic kidney disease. That may not always be the case, because sometimes CKD can present with normal eGFR, especially in the early stages. So that answer will not be acceptable. So the correct answer for 53 is option D. Okay, let's move to 54. 54 says that in order to determine the glomerular filtration rate, one must estimate the following: A, the plasma volume; B, the plasma burn, that's blood, urine, nitrogen; then C, the blood volume over a specific period of time; and then D, the urine creatinine; and then E, plasma albumin. Okay, so the correct answer here is the urine creatinine concentration. So glomerular filtration rate, one way of determining that is by doing a creatinine clearance, and in creatinine clearance you measure the serum creatinine as well as the urine creatinine. So the option D becomes the correct answer for question number 54. Let's move to 55. 55 says that plasma creatinine A is a useful screening test for the presence of renal tubular disease. B is often reduced in patients with hepatic failure, And then C is unaffected by changes in diet. D tends to rise with age. And then E, assay may be subject to interference. So the correct answer here is E, assay may be subject to interference. If you look at our options, option A says that it's useful test for the presence of renal tubular disease. So that is not the case. It's more useful when you are assessing the general health of the kidney, but not necessarily for the renal tubules. So that answer is not correct. Then if you look at B, it says it's often reduced in patients with hepatic failure. This may not always be the case, even though sometimes in hepatic failure, maybe there is reduced creatine production, which will directly affect the creatinine levels, but it may not always be the case. Then if you look at option C, is unaffected by changes in diet. That is incorrect. Creatinine is affected by changes in diet. If you take somebody who is on high protein diet, it will elevate the creatinine levels, then tends to rise with age. And this answer may not be consistent, because if you have a child, maybe the creatinine levels will be low as compared to a young adult. But then as the person grows older, where there is reduced muscle mass, so this answer at that point will not be consistent. So that's why we are not accepting that one. Then if you look at option E, assay may be subject to interference. That is true. Certain medications can actually affect your creatinine levels when they are being measured. So this option is the correct answer. Okay. Let's move to question 56. It says that which of the following is the cause of metabolic alkalosis? A, starvation. B, diabetic ketoacidosis. C, severe diarrhea. D, loss of bicarbonate from the body. And then E, antacid overdose. So the correct answer here is E, antacid overdose. If you look at the option starvation, in starvation will actually lead to metabolic acidosis, because keto acids or ketone bodies will be produced, which actually acidifies the blood. Then in diabetic ketoacidosis, that's option B, it also leads to a decrease in pH because of course the ketone bodies. Then if you look at severe diarrhea will lead to also metabolic acidosis because of the loss of bicarbonate. Then if you look at the loss of bicarbonate, of course, when by option D, when you lose more bicarbonate, it reduces the buffering capacity of the blood, so the pH will actually drop. Then if you look at option D, which is antacid overdose, yes, so this answer is the correct answer, because when you take excessive antacid, it will actually increase the bicarbonate levels in the blood, which can lead to an elevated pH. So that's the correct answer. Then we look at question number 57. 57 says that which of the following substances can be used to measure glomerular filtration rate? So the answer here, okay, the options are inulin, insulin, B, albumin, C, creatinine, D, bilirubin, and then E, potassium. The correct answer here is creatinine, because creatinine is filtered and not reabsorbed, so it's one of the best markers for glomerular filtration rate. Okay, let's move to 58. 58 says that the following color coded sample collection tubes contain additives indicated by them. So yellow top tube is coded. Yellow top tube coded. How am I reading this? Okay, it says yellow top tube coded. Yellow top color coded tube containing no additive. Contains no additive. So the red top contains fluoride oxalate. The blue top contains EDTA. Gray top contains heparin. And then lavender contains citrate. So the correct answer here is yellow top color coded tube contains no additive. Yeah, so that is the correct answer. So the yellow contains no additives, is used for serum collection. Then if you look at option B, red top contains fluoride oxide. That is wrong. The red top also has what do we call it, no additive at all. Okay, then if you look at the blue top contains sodium citrate for coagulation studies and not EDT. If you look at the gray top, contains fluoride oxalate, which is used for glucose testing. Then the lavender, that's option E, contains EDT, not citrate. Okay, then the yellow top, again, I think I made a mistake when I was explaining. So the yellow top contains a gel which just helps to separate the cells from the serum. Okay, so that becomes our answer here. Okay, question 59 says factors to consider in selecting the plasma enzyme for diagnosis include all the following except A, sensitivity, B, specificity, C, half-life of the enzyme, D, molecular weight of the enzyme, E, rate of release of the enzyme. So the correct answer here is the molecular weight of the enzyme. So it's the only thing that has not needed when you are selecting an enzyme for diagnostic purposes. If you look at the options like sensitivity is very important because it indicates how well the enzyme can detect the presence of disease. If you look at specificity, it's also very crucial because it shows how well the enzyme can distinguish between the disease of interest and other condition. Then the half-life of the enzyme too, it affects how long the enzyme remains in the blood, and that's how long it can be detected. For molecular weight does not really affect the assay consideration, so we don't consider it for any diagnostic purpose. Then if you look at the option E, rate of release of the enzyme, that also very important because the rate at which the enzyme is released into the plasma can be important, and it affects the enzyme's level and then the detection time. So enzymes that are released rapidly may provide more timely diagnostic information. So the correct option here is the molecular weight of the enzyme. Question number 60 says low levels of alkaline phosphatase are found in A, hepatocellular disease, B, cretinism, C, hyperparathyroidism, D, Paget's disease, and then E, cholestasis. And the correct answer here is cretinism. So that's the correct answer here. If you look at option A, hepatocellular disease, it's often results in rather elevated ALP levels and not low ALP levels. If you look at hyperparathyroidism, also associated with elevated ALP levels due to increased bone turnover and then potential osteitis. Then if you look at Paget's disease, so Paget's disease of the bone is usually characterized by elevated levels of ALP due to bone remodeling and then turnover. Then if you look at cholestasis, it's often also associated with, or it leads to elevated ALP levels due to the accumulation of bile in the liver. So the only correct answer here, or the correct answer here, is cretinism, which is a condition that causes severe hypothyroidism in infancy and can sometimes be associated with low ALP levels. Though ALP is not a primary marker for this condition, it must be noted. Okay, question 61. Question 61 says which of the following statements about lactate dehydrogenase is true? A says, so the answer here is D exists in body tissues as a tetramer consisting of 4 polypeptide chains. So let's go through the options. A says catalyze the irreversible conversion of lactate to pyruvate. Then B, there are at least 10 isoenzymes. C, it is found mainly in smooth muscles. Then option D exists in body tissues as a tetramer consisting of 4 polypeptide chains. And then E has a molecular weight of 88 kilodaltons. Okay, 88,000 kilodaltons. Okay, so if you look at option A, it says catalyzes the irreversible conversion of lactate to pyruvate. That's incorrect. So LDH catalyzes the reversible conversion of lactate to pyruvate. So the reaction is not irreversible. Then if you look at option B, it says there are at least 10 isomers. So this is also incorrect. There are typically 5 main isomers of LDH and not 10. So these isoenzymes are classified as LDH 1 through to 5 based on their tissue distribution and electrophoretic properties. Then if you take option C, it says it's found mainly in smooth muscle. This is also incorrect. LDH is widely distributed in many tissues, including the heart, the liver, the kidney, skeletal muscles, and red blood cells. Okay, so it's not specifically concentrated in smooth muscles. Then if you look at option D, it says exists in body tissues as a tetramer consisting of 4 polypeptide chains. So this is correct. LDH exists as a tetramer composed of 4 polypeptide chains, which can be a combination of 2 types of subunits. Okay, then if you look at option E, it says that has molecular weight of 88,000 kilodaltons. That's incorrect. The molecular weight of LDH is approximately 140,000 daltons or 140 kilodaltons and not 88,000 kilodaltons. So the correct answer here is D. Okay, 62. It says that which of the following can be classified as a tumor marker? A. Glucagon. B. CA125. C. C-peptide. D. HbA1c. Then cystine C. The correct answer here is CA125. So this CA125 is a well-known tumor marker which is used primarily to monitor ovarian cancer. Okay, so that's about question 62. Question 63 says that which of the following tumor marker is correctly matched to its associated tumor? CA, that's breast, is matched to breast cancer. CA19-9 matched to pancreatic cancer. Beta 2 macroglobulin matched to adenocarcinoma. Then carcinoembryonic antigen matched to non-Hodgkin's lymphoma. Then ECA15-3 matched to colon cancer. The correct answer here is CA19-9 matched to pancreatic cancer. If we look at our options, that's a CEA, that's carcinoembryonic antigen. It's a tumor that can be elevated in several types of cancer, including colorectal cancer, breast cancer, and others. However, it is mostly commonly associated with colorectal cancer. So this answer is not acceptable. If you look at B, which is the correct answer, CA19-9 is a tumor marker commonly associated with pancreatic cancer. Yes, so and it can also be elevated in other gastrointestinal cancer. So that's the correct answer. If you look at beta 2 macroglobulin, so this one is primarily associated with, or is a marker, or is used as a marker for lymphoproliferative disorders such as multiple myeloma and then lymphoma. so not for adenocarcinoma. Then if you look at D, it says quasi-embryonic antigen to match to non-Hodgkin's lymphoma. That's also incorrect because CEA is elevated in various cancers, and particularly associated with colorectal cancer. Then if you look at CA15-3, that one is also used as a tumor marker for breast cancer and not colon cancer. So the correct answer here is B, CA19-9, that's pancreatic cancer. Okay, question 64 is saying that human chorionic gonadotropin, A marker of germ cell tumor and trophoblastic disease. Then B, it's a glycoprotein with a molecular weight of 450 kilodaltons. Then C, it's composed of two similar subunits. D, is synthesized by the gonads. And then C, shows 10% sensitivity for choriocarcinoma. So the correct answer here is A marker of germ cell tumor and trophoblastic diseases. If you look at the option A, which is our answer, so this is correct because HCG is indeed used as a marker for germ cell tumor, such as testicular tumor, and then trophoblastic disease such as choriocarcinoma. If you look at option B, which says that it's a glycoprotein with a molecular weight of 450 kilodaltons, that is incorrect because HCG is a glycoprotein with a molecular weight of approximately 36,000 daltons, not 450 kilodaltons. Okay. Then if you look at option C, it says that it's composed of two similar subunits. This is incorrect. It said HCG is composed of two different subunits. That's an alpha subunit and a beta subunit. Okay, so the alpha subunit is similar to the ones we see in glycoprotein hormones like LH, FSH, and TSH, whilst the beta subunit is unique to the HCG, and then it provides its specific biological activity that we know. Okay, if you look at option D, is synthesized by the gonads. This is incorrect. HCG is primarily synthesized by the placenta during pregnancy. Yeah. Then look at option E, shows 10% sensitivity for choriocarcinoma. This is incorrect. HCG is actually quite sensitive and specific for choriocarcinoma, with sensitivity often reported as much higher than 10%. Okay, so it's a primary marker used to diagnose and monitor choriocarcinoma. So the correct answer here is A, which is a marker of germ cell tumor and trophoblastic disease. Okay, 65. Okay, 65 says that unconjugated bilirubin, A, is water soluble, B, gives direct Diagnostic growth reactions, then C, is not bound to protein in plasma, D, is decrease in hemolytic anemia, and then E, is increase in post-hepatic jaundice. Okay, if you look at all these options, none of them is viable, and we'll go through and you see why. So option A is saying that is water soluble. This is incorrect. Unconjugated bilirubin, also known as the indirect bilirubin, is not water soluble. It's lipid soluble and needs to be bound to albumin for transport in the blood. So that option is not correct. Then if you look at B, it says that gives direct Diagnostic growth reaction. This is incorrect. The direct Diagnostic growth reaction measures conjugated bilirubin. So unconjugated bilirubin does not react directly in this assay and requires a different method requires a different methodology to be quantified. Then if you look at option C, it says that it's not bound to plasma protein in plasma. This is also incorrect. Unconjugated bilirubin is actually bound to albumin in the plasma to be transported to the liver for conjugation. Then if you look at option D, there's decrease in hemolytic anemia. This is also incorrect. In hemolytic anemia, unconjugated bilirubin levels are typically increased because of the breakdown of red blood cells, which leads to an increased production of the unconjugated bilirubin. Then if you look at option E, it says that it's increased in post-hepatic jaundice. This is also incorrect, because in post-hepatic jaundice, that's also known as obstructive jaundice, is characterized by increase in conjugated bilirubin due to the obstruction of the bowel flow, which leads to an increased level of conjugated bilirubin in the blood. So this one too is not correct. It's not correct. So actually there's no correct answer for number 65. There's no correct answer. Okay, so we leave it as it is. Question 66. It says that in diagnosis of diabetes, A, an elevated ADH1C is very diagnostic. B, patients with result demonstrating impaired glucose tolerance are at increased cardiovascular risk. Then C, a single elevated plasma glucose result is sufficient in itself. Then D, absence of glucose in urine is not diagnostic. E, an oral glucose tolerance test is always required. So the answer we're choosing here is D, absence of glucose in urine is not diagnostic. So here's why. Let's go through our options. So in option A is partially correct. It's partially correct. It's not fully correct, because an elevated HbA1c is a useful diagnostic criteria for diabetes. However, HbA1c reflects average blood glucose levels over the past 2 to 3 months, and levels of 6.5% or higher indicator of diagnosis. However, it is often used in conjunction with other tests for a comprehensive diagnosis. So you would not use that the elevated levels of HbA1c only as the diagnostic parameter. You use it in conjunction with others. That's why we are not accepting that answer. Then B, it says that patients with results demonstrating impaired glucose tolerance are at increased cardiovascular risk. This answer too is correct, because in impaired glucose tolerance, so this is a condition where the blood glucose levels are higher than normal, but not high enough to be classified as diabetes. So people with impaired glucose tolerance are at increased risk for developing type 2, and once that happens, they also have an increased risk of cardiovascular disease. So this answer is correct, but since we are talking of strictly about diagnosis of diabetes, we will not really lean towards the answer. If we get another one that is more solid, we'll use that one. So if you look at option C, it says that a single elevated plasma glucose result is sufficient in itself. So that is not true. That is not correct. So a single elevated plasma glucose level is not sufficient for diagnosing diabetes. Yeah, you usually need to do multiple times, or do it in conjunction with other tests like OGTT and then HbA1c. Good. Then if you look at option D, which we are selecting as our answer, that is the absence of glucose in urine is not diagnosed. This is correct, because the absence of glucose in urine is not used to diagnose diabetes. Glucose may not appear in urine until the blood glucose levels are very high. So its absence does not rule out diabetes. So urinary glucose is more often used as a monitoring tool rather than a diagnostic tool. So the absence of glucose in urine is not diagnostic. That's very true. That's very true. That's a very correct statement. Then if you look at option E, it says that an oral glucose tolerance test is always required. So this one too is not acceptable. While oral glucose tolerance test is available by glucose, it's not always required. It's not always required. So diabetes can be diagnosed based on the fasting blood sugar, HbA1c, random blood sugar. It's fine. And then patient's clinical presentation, that those ones can be used. So you not always have to depend on oral glucose tolerance test. Okay, so option D becomes our best answer, or the most appropriate answer here. 67. It says that monitoring diabetes control A can be adequately achieved using urine test for glucose. B, by HbA1c measurement can be unreliable in patients with anemia. Then C, using fructosamine reflex control over the previous 40 to 50 days. Then D, using home-based glucose measurements is essential in all patients. Then E, by HbA1c measurement can give artificially elevated results in patients with hemoglobinopathies. Okay, so if we go through the options, so option A says that can be adequately achieved using urine test for glucose. This is incorrect. While urine test for glucose can provide some information about glucose control, they are not very reliable for comprehensive monitoring. So they only indicate glucose level at a specific point in time and are less sensitive and specific compared to blood tests. So urine glucose levels can be influenced by factors such as hydration and renal threshold for glucose secretion. So this answer is incorrect. Then if you look at option B, it's actually correct. It says that HbA1c measurement may be unreliable in patients with anemia and other hemoglobinopathies because it relies on the average glucose level attached to hemoglobin over the past 2 to 3 months. So conditions affecting the red blood cell turnover, such as anemia, can affect the accuracy of HbA1c results. So this answer is actually correct, is viable. Then if you look at option C, it says using fructosamine reflect control over the previous 40 to 50 days. This one too is correct because fructosamine measures the average blood glucose levels over the previous 2 to 3 weeks, which can be a useful short-term monitoring. It's particularly helpful when HbA1c results may be unreliable or when more frequent monitoring of glucose control is needed. So that answer too is viable. The only thing with this one is the number of days that they are given, which is a little bit more, which is a little bit high, because 2 to 3 weeks it's not up to about 40 days. That's about 21 days or something like that. Okay, then if you look at option D, it says that using home blood glucose measurements is essential in all patients. This answer is saying it's not really correct, it's not acceptable. So while home blood glucose monitoring is important for many patients with diabetes to manage daily glucose levels and adjust treatment, is not necessarily essential for all patients. The need for home monitoring depends on individual treatment plan and the type of diabetes. Some patients may manage their diabetes with less frequent monitoring or other methods. Okay, then if we look at option E, it's saying that HbA1c measurement can give artificially elevated results in patients with hemoglobinopathies. That's very true. You actually see elevated or decreased in patients with hemoglobinopathies or conditions that affect the red blood cell lifespan, like sickle cell and then thalassemia. So if you look at our options here, option C is correct, option B is also correct, and option E is also correct. But if we are to choose one answer, then I think we'll go with option B as our most appropriate answer. Okay, then let's move to the next question. It's a case study. It says that a 23-year-old female had her fasting plasma lipids checked by her family doctor because her father had been admitted at the hospital and diagnosed of myocardial infarction. Age 44 years. Her lipid profile results were as follows. The cholesterol was 9.4 millimole per liter. The HDL was 1.2 millimole per liter. The triglyceride was not provided. They want to quiz us on it. So the case study continues and says that the biomedical scientists had the optical density of the triglyceride as 0.09, the mean standard absorbance as 0.20, and the standard concentration of 2.20. So the question then, that's 68, is saying that what is the triglyceride concentration from the above case study? The answer is 1.03 millimole per liter. How do you get that? It's the optical density of the triglyceride, that's 0.09 over the standard, which is 0.02, 0.20, then multiplied by the concentration, which is 2.28. So if you do that, you have to get 1.03. Then 69 says calculate the LDL of the above patient. So to do that is the total cholesterol minus the HDL minus the VLDL. If you do that, you are going to get 7.73. Then VLDL, so very low density lipoprotein concentration of the patient. To get that, you divide the triglyceride by 2.2. So if you do that, you are going to get 0.47 millimole per liter. Okay, so question 71. Question 71. It says that biochemical changes and pre-analytical variations that may result from poorly stored or stale urine include A. Low pH, then B. No effect on urine protein results, C. False negative glucose results, D. Falsely increased bilirubin, and then E. Falsely increased urobilinogen. Okay, so the correct answer here is lower pH. So let's analyze the option. So urine pH tends to decrease, that become more acidic over time due to the bacterial growth and the breakdown of urea into ammonia, which lowers the pH. So that's why we're accepting option A as our answer. If you look at B, it says no effect on urine protein. This is incorrect. Poorly stored or stale urine can lead to degradation of protein or change in the urine matrix, which can affect the protein result measurement. And if you look at C, it says false negative glucose result. This is correct, but not always the case, because you may have a situation where there is no glucose in the urine at all. So this answer, we cannot depend so much on it. Okay, then if you look at option D, says falsely increased bilirubin. This one is incorrect. That's not an answer, because bilirubin is unstable in urine and can degrade if the urine is not properly stored. So that will also okay. And then if we look at what do you call it? Option E, it says that falsely increase the urobilinogen. So urobilinogen can increase in stale urine due to the bacterial degradation of bilirubin and other substances. However, the urobilinogen can also decrease if the sample is not stored correctly. So the results can be variable. So if you look at these ones are conditional. So if you look at our options, option A becomes our most strongest answer. So most appropriate to be A. Okay. Question 72. Plasma differs from serum in all the following ways except A. The plasma lacks the clotting proteins. B. That the color of plasma is more intense. C. That they are obtained from the same source. D. It generally contains higher electrolytes than serum. Then E. Plasma is usually more jaundiced. So the answer here is it generally contains higher electrolytes than serum. So see, the question again says that plasma differs from serum in all the following except. So if you analyze our option A says that the plasma lacks clotting factors. So this is incorrect because plasma contains clotting factors because it is collected into an anticoagulant that prevents it from clotting. Serum, on the other hand, which is a liquid that remains after blood has collected and thus lacks the clotting factors. If you look at option B, it says that the color of plasma is more intense. This is correct. So plasma is often slightly more yellow than serum because it contains fibrinogen, another plasma protein that can affect its color. However, the difference in color is generally subtle, so that's why we can use this answer. We can depend on this answer. Then if you look at option C, they are obtained from the same source. So it's both plasma and serum are obtained from blood, of course. So plasma is collected from blood that has been treated with anticoagulant, while serum is obtained from blood that has clotted. So that would be our answer. If you look at D, which is our answer, it says that plasma it says that plasma and serum generally have similar electrolyte concentration, although there can be slight variation. However, any difference are typically not significant. So there might not be any much significant difference for this. That's why that is our answer. Okay. So let's look at E. You say plasma may appear more jaundiced, more yellow compared to serum if there is an elevated level of bilirubin in blood, which can be due to conditions affecting the liver and hemolysis. Okay, so therefore the statement that is not a way in which plasma differs from serum is option D. That is, it generally contains higher electrolytes than serum. Okay, then question 73. It says that the most useful laboratory test for investigating suspected iron deficiency includes A. Serum iron, B. Serum ferritin, C. Serum transferrin, fecal alcohol blood, and then E. Serum transferrin receptor. So the correct answer here is serum ferritin. Okay, let's move to question 74. It says that uric acid A is highly soluble in urine, especially under acidic condition, is reabsorbable in the proximal tubules, undergoes neither secretion nor reabsorption in the distal tubules. In the end, is the end product of metabolism of both pyrimidine and purine base of DNA. Then E can be converted in vivo in a man naturally to allantoin. Okay, the correct answer here is reabsorbed in the proximal convoluted tubules. Okay, let's move to question 75. That is our last question for the day, and then we finish. Which of the following statements is true about CSF? So A says CSF glucose ranges from 2.1 to 3.3 millimole per liter. B is saying that the entire volume of CSF is replaced within 4 to 6 hours. Then C, a lumbar puncture for CSF glucose analysis should only be obtained after the patient has fasted. Then D, CSF glucose ranges from 100 to 200 millimole per liter. Then option E, CSF glucose may be low in patients with acute meningitis. So the correct answer here is E, CSF glucose may be low in patients with acute meningitis. If we look at the options, option A says CSF glucose ranges from 2.1 to 3.3 millimole per liter. This is incorrect. Normal CSF glucose levels are typically in the range of 2.5 to 4.5 millimole per liter. Then if you look at option B, the entire volume of CSF is replaced within 4 to 6 hours. This is incorrect. The entire volume of CSF is not replaced within 4 to 6 hours. The CSF turnover rate is much slower. The total CSF volume, approximately 150 mils, is typically replaced every 3 to 4 hours. But this does not imply complete replacement of the entire volume in the time frame. Then if you look at option C, a lumbar puncture for CSF glucose analysis should only be obtained after the patient has fasted. This is incorrect. CSF glucose levels are not significantly affected by fasting. A lumbar puncture for CSF analysis does not typically require the patient to fast beforehand. Then if you look at option D, CSF glucose ranges from 100 to 200 millimole per liter. This is also incorrect. CSF glucose levels are much lower than this. The normal range is 2.5 to 4.5 millimole per liter. Then option E, which we are selecting as our correct answer, is CSF glucose may be low in patients with acute meningitis. This is correct because in case of acute meningitis, CSF glucose levels can be decreased due to the increased consumption of the glucose by bacteria and impaired transport of the glucose into the CSF. So that becomes our answer. So this brings us to the 25 questions on Chem part. So watch out for the next part. Thank you.